So hi friends, welcome to the Emergency Medicine channel. Myself Dr. Ashik NV, doing post-graduation in emergency medicine. So today we are discussing about post-cardiac arrest algorithm. Yesterday's video, it was about cardiac arrest management, BLS and ACLS guidelines. So after attaining ROSK, what to do with the patient? That is we are going to discuss today. So we have obtained the ROSK. ROSK means return of spontaneous circulation. So once we attain the ROSK, we have to do the primary survey on the patient again. The primary survey includes airway, breathing, circulation, disability and exposure. That is our ABCDE. So the first step is managing airway. So after ROSK, we have to go for airway management. So airway management include early placement of an ET tube. So early placement of endotracheal tube. In most of the cases, we have already inserted the ET tube during the resuscitation only. If it is not done, you have to intubate the patient. Okay. So after securing the airway, moving on to the breathing part. In breathing part, we have to manage the respiratory parameters. So in breathing part, managing respiratory parameters. Respiratory parameters. It include start a respiratory rate. With the ambu bag, you have to ambu the patient at a rate of 10 breaths per minute. 10 breaths per minute. And you have to maintain a saturation of 92 to 98%. And the PaCO2 should be between 35 to 45 mmHg. For this, the capnography should be monitored. The PaCO2 should be between 35 to 45. Avoid hyperventilation. Okay. So after the breathing part, we have to go for circulation part. In the circulation C part, the systolic BP should be more than 90 millimeters of mercury, and the mean arterial pressure MAP should be more than 65 mmHg. So this should be maintained. So after this, we have to go for a 12 lead ECG. 12 lead ECG in the C part only. Okay. So after obtaining this 12 lead ECG, we have to consider for emergent cardiac intervention in certain cases. So emergency cardiac intervention if the following conditions are present. Either STEMI in ECG. We have obtained a 12 lead ECG and suppose it's showing a STEMI in either inferior or anterior or lateral wall. We have to shift the patient to cath lab for the percutaneous PCI or other intervention. Okay. Or if the patient is in a state of unstable cardiogenic shock. Here also the cardiac intervention should be there. Or if the mechanical circulatory support is required for the patient. Mechanical circulatory support is needed. Then also cardiac intervention should be there. So after ruling out these conditions, we have to check for whether the patient follows our command. That is, we are examining the disability part. Follow commands. If the patient, this has to be done if we are intubated and sedated, planning to sedate the patient, this step should be done initially before sedating the patient. Okay. So we are giving certain commands to the patient. We are watching for whether the patient is obeying command or not. If the patient is awake, yes, he is following the commands, then other critical care management should be considered. Then we have to go for other critical care management. Suppose he is not obeying the command, the patient is not obeying command or in a state of comatose. Then we have to consider the following things. First one is targeted temperature management. Obtain a CT to rule out any IC bleed. Okay, obtain CT. Then EEG monitoring for evaluation of seizure. EEG monitoring. And here also it include other critical care management. So we will discuss each in the later. So after, in both these conditions, after this step, we have to evaluate and treat rapidly reversible etiologies. We have to look for the reversible etiologies, which as I have already discussed in the previous videos, the 5 H's and 5 T's of the cardiac arrest. So after this, we have to go for the treatment of reversible etiologies. Okay, and also involve expert consultation if required. So these are the basic steps of the post ROSK management or post cardiac arrest management or algorithm. So there are certain newer terms or terminologies in this algorithm. We have to discuss and we have to know how to troubleshoot certain conditions. If like if the patient is going to hypotension after the ROSK, how to troubleshoot the condition. Okay, so the first thing is, what if the patient is going to hypotension? So how to treat hypotension after ROSK? Treatment of hypotension after ROSK. Okay, the first step is, of course, we have to secure an IV line. It may be already done during our resuscitation part only. So we have to give IV fluid bolus of 1 to 2 liters of normal saline or ringer lactate. If still hypotension persists, we have to consider the drugs for hypotension. So the AHA recommended drugs for hypotension after ROSK include norepinephrine, epinephrine, that is our adrenaline and noradrenaline, epinephrine is adrenaline, and dopamine. The suggested dose for norepinephrine is 0.1 to 0.5 mcg per kg per minute. For epinephrine, it is 2 to 10 mcg per minute. It is not per kg, it is mcg per minute. And for dopamine, it is 5 to 20 mcg per kg per minute. The doses of epinephrine and dopamine are same as that of in the bradycardia algorithm, which we'll discuss in the next upcoming videos. Okay, so this is how we treat the hypotension after obtaining ROSK. So now about the targeted temperature management, TTM. So TTM is targeted temperature management. So TTM is the only intervention demonstrated to improve neurological recovery after cardiac arrest. Okay, so it is done to improve the neurological outcome. So in targeted temperature management, we have to keep the core body temperature between 32 to 36 degrees Celsius. So maintain the core temperature 32 to 36 degrees Celsius at least for 24 hours. That is important, at least for 24 hours. Okay, it can be achieved by like ice cold infusion, rapid infusion of ice cold isotonic solutions, non-glucose containing fluid at a rate of 30 ml per kg. Okay, or we can use other external agents like ice box, etc., to keep in the axilla to decrease the body temperature. Okay, so that is about the targeted temperature management. Now, how to do the neuroprognostication in a cardiac after attaining ROSK. Okay, after cardiac arrest, how to do the neuroprognostication. So there is a multi-modal approach for neuroprognostication, because we cannot rely on a single value or a single parameter for neuroprognostication for a comatose patient. So there is a multi-modal approach. Multi-modal approach for neuroprognostication. And these multi-modal approach include the following things. We can use MRI and N20 SSEP, that is an electrophysiological study, and EEG for status myoclonus. EEG for status myoclonus. And our clinical examination skills like pupillary reflex, corneal reflex, quantitative pupillometry, okay, and also you can use a serum biomarker called serum NSE. Okay, we can use these much parameters for the neuroprognostication of a patient. And for the patient who remain comatose, it is reasonable to delay the neuroprognostications. So usually we prefer to do the neuroprognostication at least after 72 hours. After 72 hours of normothermia. Okay, after 72 hours after attaining normothermia. Okay, immediately after attaining the ROSK, if the patient is in a comatose state, he will be managed with the TTM. In TTM, they keep the temperature between 32 to 36 degrees Celsius. Once the patient attained the normothermia after the TTM, we can do the neuroprognostication after 72 hours. It is not after 72 hours of achieving ROSK. It is after 72 hours achieving normothermia. That is very important. Okay. So this is how we do the neuroprognostication. We have a multimodal approach. Now, what are the critical care management? In the point of view of a critical care medicine, what are the they do for the post-ROSK patient? Okay, so the critical care management include they have to continuously monitor the core temperature. For that, they are using esophageal, rectal or bladder temperature. Okay, esophageal, rectal or bladder temperature. Okay, then they have to maintain normoxia. Already told, the SpO2 should be between 32 to 38 degree, 32 to 38%, and normocapnia pneumocapnia, 35 to 45 mmHg, and also euglycemia. Okay, then provide continuous EEG monitoring. Okay, monitoring for myoclonus, and also provide lung protective ventilation. Lung protective ventilation means low tidal volume ventilation. Okay, so that's all about the post cardiac arrest management. Hope you got a simple and a general concept about the post cardiac arrest management. Thank you, and kindly consider subscription if you are interested in this kind of medical videos related to emergency medicine. Okay, thank you so much.